Okay, let's get started if it would be agreeable. Number one, my name is Dr. Deane Waldman, although my patients, often didn't have teeth, so they had trouble speaking, and they were young, not old. They didn't lose them, they hadn't gotten them yet. So Dr. Deane was much easier to pronounce, and so I've been called that forever. Please turn your cell phones off, or at least put them on silence. It is really important to me for us to have time to dialogue between you and our panels, so I'm going to sort of nudge them to, I already asked them in advance to speak rather succinctly, so we do have time for dialogue, because I think that's more important than just sitting and listening to presentations. The subject matter is Medicaid. The presumption is, my presumption is, that the system has problems. They are medical problems, they are fiscal problems, and that one of the ways that we can address those problems is by reducing the control of Texas Medicaid by Washington, and thereby restoring control of Texas Medicaid to Texas. So the thesis of this panel is to say, well, if we got a waiver of whatever, X, that mandate, those mandates, we changed some regulation and got a waiver, what would we do with that freedom? That was the question that I basically posed to our panel today, and I'm gonna, I don't wanna take a lot of time here, but I'm going to introduce them one at a time. That is, I'll introduce, then they speak, then they sit down, and then the next person speaks. The first person is our friend Darren Whitehurst, who is the Vice President of Advocacy for the Texas Medical Association here in Austin. Mr. Whitehurst received his master's in, his first master's in Public Affairs at LBJ School of Public Affairs, and then a master's as well in the Science of Healthcare Administration from Trinity. Before TMA, he worked with the Texas Hospital Association, so he's kind of got the view of both the institution, if you will, as well as the individual providers. And when he was with the Texas Hospital, he was Vice President of Government Relations, so he had that interesting, and I would consider somewhat unfortunate, job of trying to bridge a large chasm. It's my pleasure to introduce Mr. Whitehurst.
Thank you very much, Dr. Waldman. And really had wanted to start off, if I had the answers, probably would not be in the job that I am and would have made a bunch of money somewhere else. I really, so I grew up in Pecos, Texas, which is out in far west Texas, and I used to talk very slowly. I've been cured of that problem since I've worked in the Texas legislature. I think really in order to answer the question relating to the 1115 or any of the other waiver programs that the federal government has offered over the years, and there have been several, it really is important to understand our current Medicaid program and who all's covered in our current Medicaid program and who all is not, because there's a lot of people out there that say a lot of different things. So I don't know if it's possible to pull up the slide on who is covered. Maybe so. It's not the UIL.
What we need is the third grade audiovisual squad.
That's right.
Or fifth grade.
Well, I think I can describe the several charts that I have. And the first one relates to who is covered under Texas Medicaid. And basically, we cover the federal minimum across the board with two exceptions. Pregnant women and children, and the long-term care population, so individuals in nursing homes. For the pregnant women and newborns, The federal minimum is 130%, 133% of federal poverty, and we actually cover just a shade under 200%, 198% of federal poverty, we cover those individuals. On the long-term care side, we cover up to, the federal minimum is 74%, and we cover 222% of federal poverty. Other than that, we are at the federal minimum for every other population that is served in Medicaid. So there is not a whole lot of optional population that we have in Texas, and those that we do, we basically have found out that it's actually cheaper for the state to provide additional coverage and try and get pregnant women into prenatal care and post-care after they have their pregnancy than it is basically to have them uncovered. And the same thing on the nursing home clients, is that we found it's better to cover them under Medicaid than to have them not covered at all and not having any sort of care provided to them because they would not be able to afford to go to a nursing home. If you look at the actual numbers, about 70% of our Medicaid population is kids. We have about 2.9 million kids that are covered in the state of Texas. And you know, one of the factors in that is that we share a border with Mexico, which is one of the aspects relating to that. We have a very young population that has a bunch of kids, and over half of the births in Texas, I think it's up to like 56, 57, somewhere right about there. Commissioner Smith could probably tell me exactly what that number is, but we have a lot of the births in Texas are Medicaid births. Beyond kids, we have 139,000 pregnant women in the program. We have 420,000 people with disabilities. We have 376,000 seniors, and we have 145,000 parents and caregivers. And there has been a lot of talk recently about work requirements in the Medicaid program. That's probably the population that you're talking about. I don't think that you could subject kids to work requirements. I don't think you're going to subject the nursing home population or individuals with disabilities. So the Texas really has a very small portion of the population that would be eligible for something like work requirements. If you actually look at the chart showing the change in the Medicaid population in the state of Texas, back when I worked in the legislature around 2000, we had a shade under 2 million individuals enrolled in the Medicaid system. And today we have just a shade over 4 million people. There are several factors related to that, but again, I would tell you is that most of that is population growth is relating to kids in the program. If you look at the cost per member per month, okay, so this is the chart that shows what I'd mentioned about the optional population and the base population. The second one shows you the distribution of that population. If you go to the next chart, maybe. And then the third one, which is about a good time to have the chart, show the next one, please. This is what our
the arrow, there you go.
So this is what the Medicaid population since 2002 has done in the state of Texas. That yellow line that you see is the cost per member per month. And so, whether or not you give the reason for that to the insurance companies or to the Health and Human Services Commission, we've actually done a very good job in controlling costs in the Medicaid program, and really most of the caseload, most of the cost in the program relates to caseload. So this is what the payments for physicians have been since 2000. You see participation for all new Medicaid patients at 67% back in 2000, and today there were cuts in 2003, there were cuts in 2011, there were additional payments made in 2007 relating to the Frew lawsuit that resulted in additional funding for pediatric services, and then a temporary increase in 2013, 2014 as a result of the Affordable Care Act. So have increasing problems with doctors taking Medicaid, and it is literally because doctors can't afford to take Medicaid, because Medicaid is the poorest payer that we have. So as far as the 1115, the doctors are open to working with anybody to try and develop a better system. You know, the bottom line is that we need to make sure that we take care of the least of these before we figure out, you know, what else we're going to do. And I think, as Dr. Waldman said, in many instances we think that the state may be better at doing that. There are all sorts of administrative hurdles and bureaucracy that we face, and so looking forward to the rest of the group and hearing their suggestions. Thank you, Dr. Waldman.
Thank you. I will give you one example before we go on to my friend Commissioner Smith, which is I was a pediatric cardiologist for almost 4 decades. The vast majority of my patients were children in Medicaid, congenital heart disease, transposition, holes in the heart, and so forth and such. I did a procedure called a cardiac catheterization on a fairly regular basis to both diagnose and often treat whatever the child had. The average bill for my services for these procedures was between $3,000 and $9,000 was my charges. Medicaid paid $387. Period. That was what they paid. Next, let me introduce my good friend, it was a job I don't envy, Executive Commissioner Charles Smith. Governor Abbott appointed Charles Smith to be the Executive Commissioner of Texas Health and Human Services, and he started on June 1st, 2016. As Executive Commissioner, Mr. Smith oversees a system with nearly 56,000 employees that serves more than 7.5 million Texans. Now, I would point out that I don't want you to think that's an error. He's got at least more than 7 million, but when we were talking about Medicaid, he has more than Medicaid. When we're talking about Medicaid, it's around 4.4 million. Over 600 programs are within HHSC, from Medicaid to SNAP. Like everybody here except me, I think, he is a proud graduate of Texas Tech. Began his career as a volunteer in the Attorney General's Child Support Division. Sounds like a really painful, I mean, no, I mean in the sense of these children are in desperate need. And anyway, he became the division's director, and we have, as a result of his work, one of the top-ranked child support programs in the nation. It is my great pleasure to introduce Executive Commissioner Charles Smith.
Thank you, Dr. Deane. Thank you, Dr. Deane.
Got the clicker?
Yes, I have it. Well, one of my biggest challenges is brevity, but we have help on the front row. Yeah, no, and so I have good instruction, and so I'll be as brief as I possibly can be, especially when we're talking about such a important and critical issue. And as Darren pointed out, when you start looking at the Medicaid program in Texas, we didn't expand, but the legislature has been very focused on making sure that we reach populations that would still have an impact on driving up uncompensated care cost and for the greater good. And so when I look at this and think about the topic today and how we wanted to move through what the waiver means and what the vision for healthcare should be in Texas, just kind of think about it. Well, we don't really have a silver bullet, but there are several things that I want to be focused on, and so I wanted to have a few minutes to kind of talk to you all about those. First and foremost, I guess to go that way, yeah. The themes as I talk to, whether it's the Texas Medical Association, Hospital Association, and many other groups, it falls into these areas. Adequate networks, robust holistic care for patients, and effective oversight of tax dollars. I want to make sure, I feel that it's my responsibility to create the best healthcare system that we can for the recipients of our services. And it's back. Okay.
It stays on
Oh, it stays there. Okay, all right. So I'll look here then. And so one of the important things that we have to do in order to do that is, in my opinion, is to begin to transform our system. Because much like in other states and in other areas, so much of healthcare is driven by a person showing up in a doctor's office. And so there's this, they come in, there's a fee, there's a cost, there's a charge, whether or not it is, it covers the cost of the services that are being rendered, but it's still this, somebody comes in, I charge, come in and charge. And that really, in our environment, doesn't help us. And so I want to make sure that we kind of transform our system to be more outcome focused and outcome basis. And in order for us to be able to do that, is we first and foremost have to make sure that our networks are adequate, meaning that as we have the managed care is the model that we have in Texas, and I think it's a very good model, and it can be a very effective model if it's properly overseen by my agency. But the other side of that is that there's this payment flow. And there we spend more than almost $30 billion a year in Texas in healthcare. And so I believe that is a tremendous amount of money. And I'm not counting everything in that, even the area. But if we take that and focus it and run it through the system differently, where we're starting to focus on outcomes for people, what does that look like? Then if you have a person who comes in and they are diabetic, then what can we do to actually improve that person's life, output on life, where we don't want to just have them come in every 3 months and get their A1C. We don't want to just have them then, as their diabetes spirals out of control, they then are on blood pressure medicine, and ultimately dialysis and amputations and blindness and all those things, which just continues to drive up the cost, and it changes this person's trajectory on life. So how can we incentivize the system so that when that person presents to a doctor, the outcome is, let me work with them where they are exercising, where they're eating better, and where we're able to drop their A1C from 12 down to 8 or 7, even better, or 6, to where their outcome on life is much better. And we, by looking at those savings, those costs avoided in the system, we run them back through and incentivize the healthcare professionals. Because I know as well as everybody else is that when that person stops showing up in their office because they're not having symptoms or the issues, then that's going to be seen as a loss to the healthcare provider and to the healthcare system. So we're implementing pay-for-quality measures. We're making sure that we're focusing on value-based purchasing and alternative payment models in our managed care system. But we also want to and need to fundamentally begin to change the way that we deliver healthcare. Because for me, it falls into these themes, is that if we're more robust and more about being holistic in our care, and that care should be patient-centered care, then it really is going to help us drive down the cost in the long run, which means that we're being more effective in our oversight of taxpayer dollars. And so I want to kind of drill down on these a little bit more. The adequate networks, we have to think differently about what that means. And you know, we have about 85% of Texans live in large urban metropolitan areas, which leaves us with about 4 million people that live in the rural places. And if you were to look at that and think about that, out of our 28 million residents, we would be larger than quite a number of states with just those 4 million people in rural areas. But one of the problems that we have is we have shortages of physicians and healthcare providers even in these rural areas. So when you start thinking about the networks that need to be there so that we can provide healthcare to the farmer or the family or the low-income family that's suffering from high cholesterol and diabetes and hypertension and those type of things, or other bone and joint issues even, How can we deliver the care to them where they are? And so we have to think about whether utilizing telemedicine as an example, how we can incentivize the system where you have maybe doctors that begin to pool and band together and cover a larger area than they would through just their normal way of thinking about traditional medicine. And are there incentives that we can work through the managed care organizations where you entice people to move out to these areas to begin to perform practice? And what does that look like to, again, offset some of the income that they may not have from a person walking through their door, but from a perspective of driving down the cost ultimately for those individuals that are there. And so I think those are different ways that we're going to be asking these questions as we're trying to figure out the future of healthcare for us in Texas. More robust, I've talked about that. We want to make sure that we're focusing on customized, individualized treatment. It's not uncommon where you see somebody that comes into an office, they check their A1C, and the first thing you begin to do is to prescribe medicine and prescriptions, and they go into prescription therapy. And all the doctors and don't have health care providers or people that are dietitians that actually help people move through this process. One of the things that we have done in Texas through our 1115 waiver is our Delivery System Reform Incentive Program payments, DSRIP. We have these programs across the state that are trying to drive down the incidence and the high incidence rate of diabetes and high cholesterol and those type of things that we're focusing on. And so we really want to see what can we begin to do to try and treat these chronic conditions that are going to continue to drive up costs. We can look and see that 5-10% of the individuals amount to about 50-55% of the cost. So what can we do that's really focused on better outcomes for these individuals, and then start looking at how that delivery and that care can change over time. Just the other day, I had it brought to my attention about an individual that we were looking at that was more than 500 pounds, and they were confined to their room. This came through a utilization review process. And they were confined to their bedroom. They were on copious number of medications and so forth that were for mental health, that were associated with their weight and others. And every time that individual needed to be taken to a doctor, we had to call a special type of an ambulabus to pick them up. They had to change their doorway so that they could get out, and all these other things that we're building. But if you just start thinking about, this individual who is in their room, and some of the depression comes as a result of their current condition. They're not able to socialize with their family. They had small children. And if we begin to help them lose weight, work through those processes, and they begin to lose weight, begin to socialize with their family, having interactions with their children, we all know that they'll be using less prescriptions. Their mental health, behavioral health outlook is different. From that child who has an engaged parent, those children, their outlook becomes different on life. And so we can figure out how best to quantify this so that we can tell the story and what it's going to look like for us to begin to work with this person holistically, moving them from that place. And I believe it saves us taxpayer dollars in the long run. We incentivize the system to treat people and work with them differently, and we have better health outcomes. And the next one is analytics, value-based purchasing, improved contract management, are all those things that will be necessary for us to make sure that we get this done. And my very last slide is on innovation and flexibility. We'll continue to collaborate with local providers on ways that they can best come up with the ideas that will work in their communities, because you can't look at everything exactly the same, and so there will be that opportunity for people to come up with new ideas, and we need to understand them and then invest in them that we can, if we believe they're going to be effective. and to incentivize the system to be able to do it. And, you know, my role is that government kind of sets the guidepost, and then we get out of the way and we monitor to make sure that we're getting the results that we need. Thank you.
Thank you very much, Commissioner Smith. I always enjoy listening to you. Our third panelist is Mary Mayhew. Mary currently works for the Opportunity Solutions Project in Tallahassee, Florida. However, important for this panel, prior to joining them last year, Ms. Mayhew served as the commissioner for the Department of Health and Human Services for her home state of Maine. And just like Texas, Maine's HHSC is the largest agency in the state with a budget over $3.4 billion and 3,400 employees. Of even more import for us here today, Ms. Mayhew spearheaded Maine's welfare reform efforts as well as their reduction of fraud and abuse in the Medicaid program. She is personally responsible for several innovative modifications to Maine Care, which is their Medicaid program, and I certainly hope she will share them with us today. My pleasure.
Thank you very much. Good afternoon. Appreciate the opportunity to be here. We're getting about a foot of snow in Maine, so nice. I know it's a little chilly here, but no snow. I want to start by sharing a story with you when I was commissioner, of a phone call that I received and of a conversation that I had. I had a mother on the phone, and she was sobbing. Her 28-year-old son with intellectual and developmental disabilities was on a wait list. And she and her husband were struggling to continue to care for him in their home. He was starting to experience multiple seizures. He was unable to be left alone in their home. And this is what she had been told by one of my staff in the department. Well, if you make him homeless, we can put him as a priority 1 and get him on the Medicaid program to provide him with residential services, if you make him homeless. I share that story with you because we are dealing with a very critical safety net program that, as originally designed, was to support our elderly, individuals with disabilities, and extremely low-income families. And then what I want to share is that we have got to evaluate fundamentally whether or not that core mission is being effectively supported. I'm here to say that it is not being effectively supported, especially when we're dealing with rapidly aging populations, different approaches to caring for our elderly, increasing numbers of children being diagnosed with autism that as they graduate from high school are in need of an adult system. I want to touch upon much of what Commissioner Smith spoke to about perhaps in many ways a healthcare system that is not governed by efficiency and accountability, and what that means as a Medicaid program in improving outcomes and incentivizing both efficient use of taxpayer dollars to produce the highest quality outcomes. So very quickly, when I walked in, and it's all scale, right? I know those numbers sound really tiny compared to Texas. Everything sounds tiny compared to Texas. But in Maine, it was huge, and I walked into an agency that had just been riddled with one financial crisis after another for more than a decade, to the point where the agency really had become desensitized. Well, they thought Medicaid always runs in the red. You just go ask the legislature for more money. And that crisis-oriented atmosphere was dictating truly just a focus on, can we pay our bills? Not, are we effectively meeting the needs of some of the most vulnerable populations? Are we able to devote the time and energy to developing a lot of the value-based purchasing models that Commissioner Smith just outlined that take a lot of time to both develop and then to navigate the layers of bureaucracy with Medicaid? So Maine, prior to the Affordable Care Act, had expanded its Medicaid program. And during a 10-year period from the year 2000 to 2010, our Medicaid program doubled in size, both in terms of enrollment and in the price tag, doubled. During that period of time, Maine was unable to pay its bills to hospitals. not as a percentage of their cost of care, but literally for patients that they had served. So when we walked through the doors in 2011 in a new administration, we owed Maine's hospital $750 million. We had small rural hospitals that were borrowing from lines of credit to meet payroll. We had nursing facilities that had closed. And again, nursing facilities on average, I assume this is relatively consistent across the country, on average, their revenue stream is 60% or more Medicaid. So when you don't pay your fair share of the costs of a nursing facility's care, they can't pay competitive wages to both retain and attract staff. We had a home care agency, similarly, that shut down its doors. And as was mentioned earlier, privately practicing physicians, which there are few today in Maine. Marcus Welby is no longer alive and well, but many of the privately practicing physicians closed their doors to Medicaid patients or greatly reduced the number that they would care for because of the reimbursement rate. But I think the most tragic was that we had developed, or the state had developed, waiting lists for elderly and disabled individuals while we were adding 25-year-old able-bodied adults to the Medicaid program. So I described the waiting lists for that adult with Down syndrome or intellectual and developmental disabilities. But similarly, under the home and community-based services waivers that Medicaid programs offer, our opportunity to more effectively support our elderly with services in their homes, often done through a waiver, is then subject to a budget cap. And yet when you expand and provide Medicaid, hospital, physician, other services to able-bodied adults, that's an entitlement. So within those competing limited resources, our state was forced to cover the costs of that increasing enrollment to the non-elderly, the non-disabled, and establish wait lists for the truly most vulnerable, the elderly and the disabled. And the phone calls that I described, certainly from that mother concerned about her 28-year-old son, but I took calls from the 85-year-old couple with the 40-year-old adult son with Down syndrome, and their health was declining, and they were scared about who was going to take care of their son when they were no longer able to or no longer around. Or the parent whose child was about to graduate from high school and had been receiving robust services in the school system and now was going on to an adult wait list, sitting on a couch in front of a TV and regressing. Fast forward, we were able to, we had to, because of the financial crisis in Medicaid, we rolled back our eligibility. We reduced our enrollment by 25%, and we began to reprioritize our resources to support those safety net services. And what was described earlier, the reimbursement rates have been pathetic for many of the providers in the Medicaid programs. We substantially increased our reimbursement rates for nursing facilities, for home care agencies, and devoted more resources to individuals with intellectual and developmental disabilities. That's what we could do once we got beyond the financial crisis and began to focus on, through data, evaluating how well we were meeting that core mission. And then beyond that, the innovative programs around value-based purchasing, there truly needs to be nationally a much greater emphasis within Medicaid. We've seen it in Medicare, that when that 800-pound gorilla has said to hospitals, we're going to start evaluating you on your infection rates and whether or not when someone presents in your ER with a heart attack, whether you're adhering to the correct protocol. Well, Medicaid has not driven that same focus on adherence to disease management protocols, to create the kind of incentive to pay for outcomes, to get away from, as Charles described, that transactional focus and a volume-based payment structure. The more I do, the more I get paid. And in Maine, we were able to stand up health homes, which were part of the provisions under the Affordable Care Act, to support primary care physicians, providing them with better reimbursement and incentivized payment to better manage the care of individuals with chronic disease. We set up statewide integrated behavioral and primary care models. And as an example, so if you are on an antipsychotic medication, you are at a higher risk of developing diabetes. So to assess whether or not there's truly integration between those two providers, I wanted to know, is that primary care doctor regularly screening that individual who's on an antipsychotic medication, may be seen by another mental health practitioner? Is he screening him for diabetes? And the answer was no. And that is, I think, where our biggest challenge is. Healthcare has not been, and behavioral health probably more so, is not data informed in its decision making. What I think truly surprised me as we began to develop these value-based purchasing models, when we began presenting to a primary care practice data on their patient panels, ER utilization rate, they had not seen it, they were not tracking it, and it was not informing how they provided care to their patients. Now, I know I've run out of time. Brevity is also not my strong suit. So I think we've got to protect the safety net and support the most vulnerable and ensure that we have done the kind of gap analysis to truly evaluate from an objective approach whether or not the limited resources that exist are supporting those populations effectively. We've got an antiquated federal regulatory structure that is not focused on the innovative pay-for-performance models that need to derive reform in Medicaid. The bureaucratic hurdles that a state has to go through to advance common sense healthcare reforms is insane. And to think that you have to wait a year or 2 years to actually reward for performance in order to get something through the process is ridiculous, because meanwhile, people are not benefiting from the very care we're trying to provide when that has not traditionally been either the focus of the providers because of the pace at which they're having to get patients through their practice, and it is not informing the way in which they are reimbursed by the state. And I'm happy to elaborate on that, but I'll be respectful of my time concluding. Thank you very much.
Thank you, Mary. We would love to entertain questions from the audience. My friend right here, we can start with. Please identify who you are.
Dennis Borrell, Coalition of Texans with Disabilities, kind of representing the beneficiaries. I'm going to ask this question of you, Dr. Waldman. There's some things that we don't do in Texas Medicaid, like preventative dental services for adults with disabilities. We
Yes.
cut therapies available to kids with disabilities, and we don't have a reliable attendant care system for older adults and people with disabilities. Is not spending that money, in your view, smart public policy?
You know, forgive me, that's one of the great rhetorical questions, I would say. As a matter of fact, pediatrician, so bear with me here, but the place to start spending that money is when the child is 6 years old. Because the adult with good dentition had to have good dental care when he was a child, preventative and so forth. That patient is less likely to have GI problems, diabetes, liver disease, and all sorts of things related to how their GI system functions. So what I'm trying to say is the effect of good dental care at any level any age you want to name is not obvious in the short term and glaringly obvious in the long term in terms of being better quality of life as well as much cheaper for the system. Anyone want to take that?
You go.
Well,
Your state.
I'll just say that some of the things that I don't know if this is close enough, that we are doing in this area is we submitted a request to CMS, I guess now more than 12 months ago, where we would allow individuals with IDD who are living in the community to be able to come, at least if there was an SSLC, State Supported Living Center there, they could come and use the dental services that were on site to specifically address that concern. And one of the other things that we're doing is I've had conversations, I know others have also, with our academic institutions about getting dentistry programs and internships to come through our state-supported living centers so that people have an understanding of what it's like to treat someone who has IDD. because that is one of the difficulties. Because when you have people, individuals who are maybe wheelchair bound and in fragile state, 90% of the dental offices aren't set up to deal with that type of an individual when they come in and they present. And so access means that we have to begin to have people work with the population so that they can see the need and understand how they can build their offices out to where they will be able to deal with individuals that come in and with the different developmental disabilities and so forth.
Yeah, I would also add, by the way, just personal suggestion, that I think dental vans or mobile dental offices are a great idea for a place like Texas with a huge rural population, and many counties don't have doctors, 120 some odd don't have doctors, and more don't have dentists, and almost none, other than the major metropolitan areas, have pediatric dentists. Just another potential thought innovation that we should consider. The problem is, in my view, we get too much, you can't do that because this regulation doesn't allow it, or that the reimbursement schedule doesn't cover that. And I'm on my soapbox, I will admit, but I really think that Texas could do a hell of a better job for Texans if we didn't have Washington in our back pocket pulling the strings. Sir, Megan, young man here.
Thank you. Sharif Zafran, I serve as president of the Texas Medical Board. Just talking about Medicaid and talking about access, two things that are very perennial and in Texas very unique because we have a very large rural area. One thing I would challenge all of us to look at as policymakers and as innovators is disruptive type of innovation. We've talked about patient-centered medical homes. We've talked about teledoc or telemedicine, which, our agency's been very much involved in, and we've put some rules out there. But why haven't we talked about a virtual patient-centered medical home? From the standpoint that we know that our problem, whether it be Medicaid or whether it be physician access in rural areas, is preventative management of these patients out there. And that doesn't necessarily require the physical visiting of a patient to a provider on a regular basis. I mean, sure, they do need to do it once in a while, but why can't we bring the virtual doctor and the virtual nutritionist and the virtual physical therapist to those areas out there which will never have appropriate access just simply because of geography and because of demographics? I think that kind of innovative thinking and setting forth Medicaid reimbursement schedules, incentivizing providers to be able to do it and to be paid for that, then we really start to get at the crux of where we are, because I think driving economics to try to put people in places where they're never going to go is just never going to solve the problem. We just gotta really have to think of it in a different way. Amazon is sending drones out to houses to deliver services, yet we're still stuck in trying to have a physical plant. I think we kind of need to think a little bit differently.
I'd like to just comment a little bit about
Mary,
that.
speak.
I think that what has been sorely lacking in the commitment to what is needed in order to accommodate that is the emphasis on health information systems, data analytics, and predictive data analytics, and staffing structures and certainly payment models that support all of that. That has not, when you think about the funding that has been available federally, it has largely been focused on facility-based supports related to health information systems. If you are a primary care physician practice that has been affiliated or owned by a hospital, you have benefited from some of the capital infusion around health information systems and connectivity within that system around health information system. If you are not, you likely have not had the resources to invest. If you are behavioral health, you have not had any assistance federally with financial supports to invest in what we all think about today. I mean, you use Amazon. I mean, we all think about where we are from a technology. If I look at a dress online, every time I go look at anything else, anywhere, that same dress is popping up 100 times. And yet, when we talk about the fundamentals of electronic medical records and the accessibility of that record no matter where I am, the healthcare system is not Amazon, which is also part of the problem with the government responsibility and role. It's not the private sector. There's not customers that can go walk away and take their business elsewhere, or a board of directors holding feet to the fire. But I think as we start to design these payment systems, and as the Centers for Medicare and Medicaid Services think about flexibility, they need to be designing matching rates that reward for investment in data analytics and that remote monitoring. You know, I have seen models where you bring an iPad out to those homes, and that individual is then connected with a nurse care manager and a nutritionist, and they are, without anyone having to travel, remotely monitoring their health stats, and when there's a concern, they're either talking them through that or bringing them in. Basic, fundamental technology that in so many other aspects of our life we take for granted that truly are not where they need to be in our healthcare system.
I would like to add one little quickie for you, just what you said, which is, imagine that facility available to a home where there is an asthmatic child. They don't know how to make the home hypoallergenic. They don't know how to, but we could teach them, you know, shampoo the dog and have hypoallergenic pillows and these other kinds of things that will forestall the acute asthma attack. There was
So
another.
just
Yes,
on
sir,
that-
in the back.
The third slide is where I was touching on utilizing technology and through telemedicine. We currently are using more telepsychiatry in our state hospitals and state support living centers
I would say
now,
we're
and we're
leading there,
continuing to do that.
Charles.
Because they're, and what I'm challenging us to do, and we were able to get funds from the legislature, is that we're going to reimagine how we deliver mental health care. And we're going to build the systems to where you don't have a person that is picked up and taken 300 miles away and put in an institution, but we're going to actually build the system where there is a group of networks and the step down in the levels of care where people can go to a facility for telepsychiatry, because in Texas, and me from being rural Texas, I can tell you there are tons of areas where you can't get connectivity. And so you create another aspect, which you're going to be able to get people to where they can go to a place where they can be connected, where they can get those services, and we're going to have to build out the infrastructure to be able to do it.
I would like to comment one thing on that. It's sort of the rules and requirements in the Medicaid rules of participation for physicians is still, a lot of them are based upon the fee-for-service world that we lived in. And so really they're not looking at the innovation. And so the doctors are being judged by the OIG based upon a fee-for-service model that may not include the innovation opportunities. And so as we move forward, really have to focus on that, is making sure that you know, the doctors are already being inundated. And you talked about the EMR and EHRs. You know, all the innovation you're talking about, really the doctor, because the doctor is oftentimes the nexus of providing healthcare services. And so all of that responsibility is being dumped on the doctor. You know, having an appropriate EMR that can communicate. And again, the doctors, I want to help be problem solvers, but the requirements and rules, we need to streamline those, and really they need to be 21st century related, and not, again, recognize we're not living in a fee-for-service world, and we're probably not going to go back to a fee-for-service world. And you know, the doctors are uncomfortable about that. I think the doctors are willing to move forward. And again, lots of very positive things. It's just trying to make sure that if they deliver services in that the OIG doesn't come knocking on their door the next day and saying, you're defrauding the state because you
And we're having those, great points, Darren, and we're having those conversations that we haven't transformed our system. We implemented managed care, but everything on the back end is still fee-for-service and counting widgets.
Right.
Even the data that we have today,
Yes.
it tracks and counts the wrong thing. We have copious amounts of data, but if we can't project and predict what outcomes will be and how to get people to work differently, then we're going to continue to spend. And I'm committed to get us beyond that.
And you know, the challenge is not only on the operational side, it's on the legislature side, educating the legislator on that. But because, you know, the last 3 cycles in the Texas legislature, we've had cost savings riders.
Right.
So you identify savings that, you talked about plowing back into the system. You know, the legislature wants those dollars. And again, doesn't it allow you to develop a platform, a better platform for the future for these populations we're serving?
Good thing is I've had conversations and will continue with legislators about how we can fund the system with the funds that are in it without asking for more if we can reinvest those dollars into the system. That will allow us to do that.
Well, and I would just add to that, because that's exactly what we experienced. When you have the time to begin to evaluate the efficiency and the effectiveness within the system, to conduct a rate analysis, to look at preventable expenditures in the system and drive improvement, it frees up resources that then you are able to reinvest. So it is not just coming in and asking for more, it's how do we effectively use the resources that are today committed. And the only other thing I would say is that under the federal Medicaid managed care structure, it's also not incentivizing the right things, which traps providers in this structure that is preventing the kind of innovation.
Well, and really the only reason that probably we have a participation that we do is based upon the geography and demographics of the state. Is that if you're a pediatric doctor, you're gonna have to see Medicaid. If you live along the border, you're gonna have to see Medicaid, because if you live in rural Texas, you're gonna have to see Medicaid. That's the population that you are serving, because that's who your neighbor is, so.
Megan, the young lady in back?
Yeah, I just have two quick comments from the trenches.
Give her the microphone.
In theory to talk about, I probably don't need that. It's all well in theory to talk about we're going to do outcomes, but I've already seen how those can be finagled. And why, since in education the vouchers work so well, why aren't we doing that with healthcare? Because I can tell you who the best pediatricians, the best behavioral therapists, I know because people go there. So why not let the system shuffle it out? And why?
You mean, why not let the
and-
patients
in all
shuffle it out?
The patient, thank you. In all due respect to government, I mean, I just think you guys need to get in the trenches, give these parents and the kids the money, and it's amazing how they instinctively know what works for Billy or Johnny. And that's the only thing I'd say, because this business, all the outcomes and whoever does it best, has been tried, and I'm telling you, it can be finagled, and it's very costly.
There's a gentleman over here, Megan.
I almost feel like I'm beating a dead horse on the back of that last conversation that was held up there. My name is Vimhead. I'm a provider here in Houston and in a surgical center group. And we don't treat Medicare or Medicaid patients because the pay, as Ms. Mayhew said, is so much less. But the bigger issue is the regulations are so much higher than anything else.
Yes.
And so if you want to look at the wet blanket on all of this, it's the regulations that stifle innovation. And so, Commissioner Smith, I'd love to see your organization and TDI begin to look at regulations that can be stripped away, that are really handcuffing the innovative Texas spirit to be able to find solutions that can benefit the entirety of the population of the Medicaid group and get them out of Medicaid and moving on with life. And so if we can get the wet blanket of regulations off of this, it would be amazing.
I was going to actually give my colleagues a question, but you sort of gave the answer. And the question is, why is it that we are spending so much more and more and more, and yet the patients are getting less and less value for the dollars they're spending? In other words, where's the money going? And I think you just answered the question. That's just my view. I think the regulatory apparatus, the compliance that we have to go through, that doesn't help patients at all, costs money, costs time, and costs opportunity. Other questions? Young lady here. And you're going to be the last, so make it the best.
I'll go ahead and second what he said and what you said. My background, my name is Kylie. I'm actually an ER nurse by training, and now I'm in clinical management. So terms like value-based purchasing and outcome-driven incentives are very familiar to our world now. One of Texas Public Policy Foundation's values is personal responsibility. So at what point is your Medicaid patient responsible for their care? Like I said, I'm in a background in ER. We give you all the tools and all the funding and everything, and yet the choice isn't made by the consumer to actually follow through. What is being done to incentivize people to come off Medicaid and these other safety net programs and keep them as safety net programs?
Can I just jump in real quick on
Mary,
that?
please speak.
I mean, personally, I don't believe that Medicaid should have the expansive role that was envisioned under the Affordable Care Act. I think it does need to be focused primarily on those critical populations, our elderly, our disabled, low-income children. The pathway out of poverty is to provide individuals with the resources to get good-paying jobs, to be able to afford the employer-sponsored coverage, to be able to afford coverage in the exchange. The problem with the federal regulatory structure with Medicaid is that it has not allowed for the kind of support around personal responsibility. So a waiver that I submitted before I stepped down tried to increase some of that by motivating the right use of the system. So when you're going to the ER for a non-urgent, when we studied some of the use of the ER, one of the highest uses of the ER was diaper rash. So where are we able to create appropriate incentives for individuals to use the system more appropriately? But Medicaid federally has really stood in the way. You know, when you create this, even though it's a partnership, most of the regulations are absolutely governed by the federal government, and they have had the wrong focus, the wrong emphasis that really does not take into account either the personal responsibility. The regulations are so inane. You sit in rooms with staff in these agencies and at the federal level, they all think they're saying something that sounds like common sense in English, and they've just been saying it for so long, it sounds right to them. In fact, it's ridiculous what it has created for challenges, for just straightforward, are we delivering high quality, efficient care, and are people using the system effectively?
And I would just, echoing what Mary said and Darren earlier on his slide, is that, you know, Texas didn't expand Medicaid. And so you have about 4 million children, 3 million children in Medicaid, and of the 4 million individuals that are on Medicaid. And then you have about 300,000 that are pregnant women. And then you're dealing with another 500,000 or so that are aged adults and those with developmental disabilities. And so and then the other section deals with caregivers who have a child that's on Medicaid. But what we can do is to look toward ways of making sure that those individuals who are Medicaid recipients are properly engaged in the system. And I think that's where, and we can begin to be creative as we start looking at the future, whether that's a global waiver and what that begins to look like, because I have some thoughts in the ways that we can incentivize a person to really take charge and control of their own personal health outcomes that can help drive down behavior, and make sure that they're accessing the healthcare system in the right and proper place. Without going to the emergency departments and those type of things, for things that they can go to their primary care physician for and so forth. But we'll have to do it through a waiver because, as Mary pointed out, the CMS regulations don't allow it in our current environment.
Well, and I think looking at sort of frontline people that have been providing the service is a good way to do that. And so I think that the 1115 provides a lot of opportunity. You know, I'm sure you as an ER nurse saw a lot of people with mental health related issues that showed up at the ER. You know, probably if they had been stabilized on medication and had taken their medication, then they probably wouldn't have been in the ER. And that's really one of the challenges. So you look at the population that is subject, that would potentially be subject to work requirements. So you put them to work. They get kicked off of Medicaid because they don't meet because they exceed the income requirements. They have mental health issues. They end up in a devolving spiral right back into where you saw them in the ER. Is that, we really need to be very thoughtful in how we're dealing with primarily a low-income population and making sure that we're developing a system that will allow them to be successful in the future. And again, is that want to be real careful with that population in particular because they are a high cost. They are a high cost on the county and city level of government. They're high cost on the state. They consume a whole lot of resources. And again, if you had them in a stable environment, they wouldn't be a high cost.
I'd like to thank our panelists. Please give them a nice round of applause. I appreciate their time and thoughts.
Thank you.
Thank you very much.